Welcome to the second monthly webinar of AFOMP. So today we are likely to have Dr. Eva Bezak to give us a talk. And our moderator today is Dr. Natalka Suchowerska. I hope I'm right. Dr. Natalka has a career in medical physics approaching 40 years. Her work as a clinical physicist and educate and meant a research advocate, a leader, and a scholar lead to her publishing over 200 peer-reviewed articles and with over 3,000 citations, hold an IP being awarded the honored member of ISTRO for 2021 and being named as the FR as one of the 100 women of influence in Australia. So now I would like to hand my microphone to Dr. Natalka. He will moderate today's talk of Dr. Eva. So please, Dr. Natalka.
So thank you very much for that kind introduction. Today we have the second monthly webinar for AFOMP, and in being asked to introduce Professor Eva Bezak, it wasn't an easy task, and I'll try and explain why. Eva has many aspects to her career. Some of you may be aware that following a long career in medical physics in the clinic, she was the director of medical physics at Royal Adelaide Hospital, the professor in medical radiations at the University of South Australia, a professorial lead at the University of South Australia. So this is amongst all professors in all areas at the university, has served as the Secretary General of IOMP and is now the Vice President. She's also got an extensive research career in cancer radiobiology, in modeling of radiation effects, in novel microdosimetry, and targeted radioimmunotherapy, all really innovative areas. This has led to a great career in fostering and mentoring the future of medical physics, a career in medical physics education, having mentored and supervised more than 5 postdoc fellows, 30 PhD students, 13 masters, and over 15 honors students. And this is just those that I'm aware of. Senior author in over 200 publications, 3 books, over 300 conference presentations, and over 60 keynote speaker invitations. And so it's hardly surprising with this sort of track record that she's been a national and international award-winning physicist. She's been an advocate for women in medical physics, a strong international advocate for women in medical physics, and those who maybe have a harder access into this career path. In Australia, she really does sculpt the future of our profession, contributing to the future accelerators in Australia with the Australia Academy of Science, also contributing at a very senior level to the tripartite National Radiation Oncology Plan, which governs how these services are provided in Australia. And this is all enabled by having really strong relations with the manufacturers, with consumers, and with the health sectors. So areas way beyond just medical physics. So if we try and summarize all of this, we can say that Eva is an all-round expert in all the different areas in this field. And so it's a great honor to have Eva speak to us on this occasion. And I'm sure you'll all enjoy this presentation just as much as I will. And I'm very much looking forward to hearing Eva speak. But before I hand over to Eva, I'd like to just remind you of some housekeeping. Please mute yourselves and turn off your videos. Please, if you have any questions, type them in the chat box as the presentation is given, and I'll be watching and summarizing them so that they can be answered in the Q&A session at the end. If you're concerned about the CPD that you'll have from attending this session, there will be feedback forms sent to you at the end. Please complete them, and you will need to attend over 30 minutes of the presentation in order to attract the CPD points. So it's a great privilege to be able to hand over to Professor Eva Bezak, who will speak about the review of cumulative doses from radiological imaging and the risk of cancer in children and young adults, a topic which concerns many of us. Thank you, Eva.
Oh, thank you, Natalka, for such a fantastic introduction. So that was really, really very kind of you, and you have now put a lot of pressure on me. So can I please share my screen now? Okay, thank you. And can I confirm that my screen is visible?
Yes, yes.
Okay, wonderful. So thank you so much for joining me this afternoon, that you have found time in your busy days. And I will be talking about a topic that was already introduced by Natalka, based on some of the review of the literature that I have conducted with two of my colleagues, namely Professor Loredana Marku and Mr. Shane Min Chow. This is the outline of my talk. I will be talking a bit about the radiation damage and imaging doses, especially in regards to cumulative doses, introduce the topic of age and gender dependence of radiation risks. We'll bring up some specific aspects of pediatric imaging, and then I will summarize the literature evidence on potentially harmful effects of imaging in small children and young adults. I will just start. I don't want to talk too much radiation biology, but only as a brief summary. We are all aware that the exposure to ionizing radiations, whether this is photons or particles, causes production of ionization events in the cells and in the DNA that then leads to the production of free radicals and chemical damage, and finally to a biological damage that can be presented on a short time scale, perhaps a cell kill, but on a longer time scale, radiation damage can lead to cell mutations and cancer to be presented later in the life of an exposed individual, which of course then has a detrimental effect on their lifespan and well-being. In terms of radiation exposure, we define the level of exposure in terms of radiation dose, with the low dose exposures being somewhere between 0 and 0.2 sieverts, intermediate exposures between 0.2 sieverts to 2 sieverts, high exposures between 2 and 10 sieverts, and ultra high exposures above 10 sieverts. But it is not only the total radiation dose that an exposed individual will receive, it is also the dose rate at which this exposure will be delivered. And usually for occupational health and purposes, we are looking whether the dose rate was low or whether the dose rate was higher per period of time, in this case in minutes. The dose rate is very important because it allows the interplay between the accumulation of radiation damage and the repair of damage, with high dose rates being more detrimental to our cells. I'm only going to talk about medical imaging in this presentation. So it might be worthwhile to familiarize ourselves with the standard effective doses delivered during certain procedures, starting with bone density exams, that deliver only about 2.5 microsieverts to a patient, through abdominal CT, where we're talking now 7.6 millisieverts, about 30 times more, with angioplasty or fluoroscopy procedures being at the other end of the spectrum, delivering between 50 and 30 millisieverts. In terms of, for example, one chest X-ray or one CT scan, we are not really worried whether one imaging procedure is representing a risk or negative outcome for a patient, because as I look at this graph, where on x-axis I have dose in milligrays, I apologize for the poor contrast on this graph, versus the natural background or the natural mortality of cancer at this stage, you know, in countries where the average lifespan is over 70 or 80 years old, 1 in 3 people will die of cancer as a result of that long lifespan. The chest X-ray or a single CT scan is not really increasing the risk of death due to imaging. However, what is a problem in the imaging is the cumulative dose, which is a result of multiple imaging procedures throughout the lifetime of a patient. So we have a definition of cumulative dose, which in medicine is the total amount of a drug, or in our case, radiation given to a patient over time. For example, the total dose of radiation given in a series of radiation treatments. And although the radiation exposure and risk from a single procedure is mostly negligible, it is the cumulative risk from multiple studies, and this is even more increased in young and middle-aged patients, that is a matter of concern. We also need to be aware that the risk is not necessarily additive. We have limited evidence still that this will increase with repeated exposures during lifetime, and they're at very low doses. It is very difficult to discern the additive risk from imaging from the natural background, as I shown in my previous slide. So really the point to take home is that the dose keep adding up and are potentially increasing the risk. So we always have to have a Lara principle in mind, as low as reasonably achievable. And we have to really think about the justification of imaging and optimization of an imaging procedure when it is applied to our patient. This is, as I mentioned previously, really exacerbated by the age of exposure. If you look at this graph from the publication of Weiser et al. Some 10 years ago, what we see that the lifetime attributable risk of cancer per individuals exposed to 10 milligray of radiation dose only is significantly increased for children under the age of 10 as compared to the population over the age of 45. Secondly, what we see that there is a significant difference between the risk of development of cancer between the male patients and female patients, and maybe at the age of 1 year, females are twice as likely, or the risk for female to develop cancer is twice as high compared to male patient. This is primarily given by the sensitivity of the breast tissue and increased risk of breast cancer in the female patients. So very quickly, a few words on pediatric imaging. Pediatric imaging really is a cost-benefit analysis. Coming to that justification, we know now, as of some last 15 years ago, that medical imaging, especially with the CT scanning, is now the largest contributor to the man-made imaging of man-made exposure of public and patients, and it has now approached the background radiation. Children are more vulnerable to radiation, and on top of that, they have a lifetime to manifest potential radiation effects as compared when you are irradiating for imaging a 70-year-old person. As per my previous slide, radiation risk in children is 2 to 3 times higher than that in people above the 45 years. However, coming back to the justification, if medical imaging is used appropriately, it can absolutely help doctors and other medical professionals save children's lives by diagnosing disease and injury. Additionally, imaging tests can reduce the need for surgical intervention and shorten hospital stays. So it's really the benefit of imaging to diagnose the disease and triaging the patient that outweighs the risk from imaging. I will use a couple of IAEA slides. If you want to learn more about the pediatric imaging, IAEA is a wonderful resource for you. We now know that the frequency of CT examinations, for example, is equally distributed across all ages. It's not really just the adult population or elderly. And surprisingly, 33% of all CTs are performed in children under the age of 10. Also very surprising that 30% of adults and children have 3 or more CT scans. So repeated examinations have now become quite common. And as I mentioned before, it is these repeated examinations that lead to cumulative dose that then increase the risk of negative side effects. The risk of developing cancer, as I mentioned before, should be evaluated against the statistical risk of developing cancer in the entire population. IAEA uses these statistics. The overall risk of cancer death over a person's lifetime is to be 20%, 1 in 5. If your country, like in Australia, has a very large lifespan, over 80 years, it could be 1 in 3. The risk of 1 in 5, what does it mean? That for every 1,000 children, 200 will eventually die of cancer at the end of their lifespan, even if they were never exposed to medical radiation. The additional risk from a single CT scan is controversial, but it only adds additional fraction to this risk, additional 0.03 or 0.05%. So again, I'm driving the home message. The individual scan is not an issue. It is the cumulative effect of repeated examinations. So, bringing me to my topic of the cancer risk in pediatric imaging. What is the cancer risk? And how do we find real evidence? One way to identify evidence, yes, you can conduct a clinical trial at your institutions, you can review all the data, but this is usually extremely time-consuming and requires evidence. But we also need international collaborations. So really, at the moment, one of the benchmark approaches to identify evidence in healthcare and evidence-based practice is to conduct systematic review of literature published all around the world. What is a systematic review? It is a form of literature review which is focused on a single issue. You know, does imaging cause increases risk of cancer in children and young adults? And which attempts through a set procedure, it's not just Googling papers that I like, to thoroughly identify, appraise, evaluate, select, and synthesize the best possible evidence from all around the world. A systematic review can confirm or refute whether or not current practice is based on relevant evidence and to establish the quality of that evidence. Because believe me, there are lots of papers out there that do not always present good science or present good statistics and sample size. Remember, systematic review is a set procedure of defined steps. What are these steps and where can I find them? The best procedure to follow is known as Prisma Statement. This is the website for the Prisma Statement, where Prisma is an acronym for preferred reporting items for systematic reviews and meta-analysis, where meta-analysis is a special mathematical analysis of data from systematic reviews, and it's really the top level of clinical evidence that we can find nationally and internationally. However, in my talk, I will be only talking about systematic reviews. As a matter of fact, because medical physicists often advise clinicians and often advise their governments about the guidelines, about the best practice in imaging or radiation therapy, I personally feel that all medical physicists should be trained how to conduct systematic reviews and should be familiar with Prisma guidelines. So what is the process of a systematic review? You have to start with an appropriate research question. You have to generate a protocol, the recipe for the review. You have to search for the evidence from at least 2, if not 4 databases. You have to include all studies that are relevant to your research question. You have to critically appraise the methodological quality. Then you need to extract the data from included papers. You have to synthesize the data, summarize the evidence, and then provide an answer to the clinical question. I emphasize that literature review is not putting some keywords into Google and looking at the 10 papers returned by Google, first 10 papers. In order to construct a literature search, your search strategy is very important. If your search strategy is poor, you will not identify all relevant literature that is available. And your search strategy should be set up around something that we call PICO framework. PICO is an acronym, PICO, that starts with patient population. In my case, the patient population is children and young adults, including neonates, recently born children. I stands for intervention or issue. So in my case, I'm looking at medical imaging. Comparison of the intervention, is imaging detrimental, where outcome of interest is maybe induction of cancer as a result of imaging. And based on these 4 points, you can identify your search strategy. So now coming to the back of my talk, my research question was, how much is too much? Systematic review of cumulative doses for radiological imaging and the risk of cancer in children and young adults. And I find the more details of the systematic review in the journal called Critical Reviews in Oncology and Hematology, published in 2021. In our case, we have searched 2 databases, Medline and Scopus, and these are some of the search terms that we have used. We have exported all citations and duplicates were removed because Medline and Scopus can potentially pick up the similar citations. Always, the titles and abstract are screened by 2 independent reviewers for assessment against inclusion criteria for each component of the review. And only studies that meet the inclusion criteria are then retrieved in full, and you conduct a second level of quality appraisal whether the study that is published meets the quality that you are seeking to evaluate. This again needs to be evaluated by at least 2 reviewers. In our case, we use the Critical Appraisal Skills Program, or CASP tool, which is widely used. Our inclusion criteria was randomized clinical trials, controlled clinical trials, prospective and retrospective cohort studies, case series, but they had to have minimum 10 patients and more, English language, studies of human participants only under the age of 18 years, and studies with inclusion of at least 10 participants. Our exclusion criteria were animal studies, cadaver studies, case series of less than 10 cases, technique reports, conference abstracts, and literature prior to 2010. The reason that we looked at the literature after 2010 is to really evaluate the evidence of the latest imaging techniques. So this is the Prisma flowchart results. We have identified a total of 420 papers. After removing duplicates, we were left with 405 papers. Upon first screening, we have excluded 337 papers as not meeting our selection criteria. And we have screened nearly 70 papers for full text evaluation. Again, with the full text reading, 23 papers were found ineligible. And the final number of studies that were included in the systematic review were 45 studies. We have identified 6 studies that included head irradiation, including dental and thyroid irradiation, 3 studies for chest examination, 10 studies for cardiac irradiation, 8 studies for spine and bone, 4 studies for abdomen and pelvis. But we also have a group of risk of second cancer studies where patients potentially have already had prior imaging due to cancer therapy. We also included registry studies in this case. So I will start now presenting some results. This will be a bit full on in terms of that there will be lots of tables. I am not presenting lots of the results. And after each table, I will have a bit of a summary and a take-home point. Again, for more details, I am referring you to the publication. In this case, in case of dental imaging, we are comparing dental radiography with dental cone-beam CT. That presented to us that the median dose that the patients mean effective dose that the patients received in the dental radiography was 4 to 21 microsieverts. And this particular study has looked at 3 patient cohorts of 5, 10, and 15-year-olds and looked at both sexes. What they identify that the mean risk in panoramic radiography varied from 7 to 3.5 per 10 million procedures for male patients, and from 9 to 10 per 10 million of female patients, showing to us that the risk again was higher for female patients and was reducing as a function of age. So when you are doing risk assessments, you should be really taking into account age and gender of the patient. How about head and skull imaging? We have two studies, one including 320 patients. This was diagnostic X-ray imaging for head injury. And one was 104 children under the age of 6 that were imaged for cerebrospinal fluid shunt placement with a CT. Interestingly enough, both of these studies reported that there was no association between head injury and the exposure to diagnose that injury and subsequent brain cancer. And the second study that looked at two groups, children under the age of 1 year that are extremely sensitive, and the second group was between the ages of 1 and 6 years. Neither groups developed any tumors, solid or blood cancers during a 10-year follow-up, which is very positive. Thyroid exposure. I have selected a couple of studies. Here we have CT scans. We have 922 patients in the study 1, and we have pooled analysis of 1,000 pediatric patients that included cancer survivors and children treated for benign diseases in study 2. The doses ranged from 0.6 millisievert to up to 6 millisievert, resulting from chest CTs. The study concluded that chest CT caused higher incidences of thyroid cancers than a CT for head or parasinal sinuses. So perhaps if you don't have to use chest CT, but you can use a chest X-ray radiograph, this would be a method of choice. The second study identified, this is a pooled analysis, 252 thyroid cancers in irradiated children and 142 cases in non-irradiated children. So this study actually identified increased relative risk with radiation dose. This was a significant finding, which was very close to a linear relationship. So there was a 37% radiation-associated thyroid cancer cases estimated for doses of less than 2 grays, 200 millisieverts. The study confirmed that there was a linear dose response in terms of thyroid cancer development. So conclusions derived from studies on head and neck exposures. Long-term risks in dental CBCT can be up to 4 times higher than for normal from intraoral or panoramic radiography. Female patients have higher risk than male patients. CT exposures following head injuries showed no association with brain tumor development, and pooled analysis of 9 pediatric patient cohorts of 1,000 patients in total confirmed a linear relationship between dose response in terms of thyroid cancer development. Let's move from the head now to the chest imaging. In case of chest imaging, we looked at the CT of the chest, and the studies have ranged from 30 patients to up to 552 patients. Reported doses were ranging from about 2 millisieverts per patient to up to about 37.6 millisieverts in the second study. The first study identified that the risk index was only about 1 case per 1,000 patients exposed. The second study confirmed that the chest radio CTs had a very good correlation to information provided by chest X-rays. However, the CTs did not change patient management. At the same time, CTs severely increased the dose to a pediatric patient. So if you are not getting any more information to change the treatment of the patient from CT as opposed to X-ray radiograph, X-ray radiograph should be the primary modality for the chest imaging over a CT. In the last study, which involved much younger patients, they were under the age of 5, they confirmed that there was a total risk of 0.34% for females and 0.5 in males of the age of 10 years for organ-specific cancer risk. There was nearly 2% risk for the thyroid cancer, 0.5% increased risk for stomach, 0.5% increased risk for lungs, and about 0.4% for breast in female patients. So in conclusion, organ dose to the chest after CT exposure and the risk of cancer decreases exponentially with increasing chest diameter. Cancer risk decreases exponentially with increasing patient age. And it was confirmed that the chest diameter is actually a stronger predictor of a CT dose than the patient's weight and the total scan length. So measure the separation wall for a chest diameter. Plain radiography should be the first choice of imaging when evaluating thoracic spine injury in pediatric female patients. Clinical information offered by chest radiography for blunt trauma is a good correlation with the information provided by CT with greatly reduced radiation exposure. What about cardiac imaging? Again, we had a number of studies, I have not mentioned them all, varying from 59 patients to up to 5,000 patients under the varying ages. The studies have confirmed some marginally increased risk. I am not going through all the tables. The first study have confirmed that there was lifetime attributable cancer risk of 1 in 382. The total corresponding estimated lifetime attributable risk of fatal cancer for all combination of ages for up to 15 years was 1 in nearly 2,000. This is comparable to the second study where they looked at the confidence interval limits that varied to 2 to about 2,000 cancers per 100,000 patients exposed. I will summarize rather than going to through the table. There is a large number of radiological procedures for cardiac imaging, and this is primary because these children have been born some cardiac defect. They need often open heart surgery. They have a congenital heart disease, and they undergo a large number of radiological procedures. This is potentially resulting in cumulative doses. Number of papers suggested that there was a suboptimal management in the clinical practice pediatric cardiology, and new protocols should be developed that are looking at the minimizing of radiation dose in cardiology. The greatest concern during cardiac procedure is the risk of breast cancer, which can be reduced by avoiding breast exposure in lateral projection. Also, image optimization is required through careful setting of fluoroscopy and imaging system parameters, including source to image distance, camera magnification, collimation, beam quality, anti-scatter grid, as these all have strong impact on radiation dose. Let's have a look at the abdomen and pelvis. Again, I only have a selection of several studies. Abdomen and pelvis have actually been related to quite large doses. For example, in the study 1 with 53 neonatal patients, this was leading up to 6 millisievert of effective dose to patients, which is comparable to study 3. The studies identified the maximum and medium cumulative lifetime cancer mortality risk of 1 point to 1,500 and 1 point to 130 respectively, meaning that the cumulative mortality risk was a median of 130 times fold and maximum of 1,575 fold increase. The second study identified associated radiation risk estimates per procedure to range between 80 to 130 cancers per 1 million procedures. One thing that we have identified, as you can see to me, which we found a bit of a problem, that there is no uniformity on what people are reporting as a risk. They might be reporting cumulative risk, excess risks, odd ratios, LARs. So it's also very complicated and complex to compare what we call apples with apples. The third study concluded that the highest cancer risk was associated with liver in both genders in the age group 0 to 4 ages of age. So conclusions derived for abdomen and pelvic exposures. Diagnosis and post-surgical follow-up of certain congenital digestive malformations involve large cumulative doses of radiations in newborns. And these doses were estimated to be up to 3 times or maximum of 42 years of natural background of radiation during that neonatal period under the age of 1 year. Patients with Crohn's disease undergo a series of diagnostic radiological procedures that by adulthood can lead to cumulative dose of more than 50 millisievert, which is a threshold level suggested of increased lifetime cancer risk. So repeat abdominal imaging has definitely been linked to increased lifetime cancer risk. Measures should be implemented of reducing the number of radiological investigations, and cumulative doses are required in all abdominal radiological procedures currently used in congenital digestive malformations. Clinicians treating pediatric patients with renal, now kidney disorders, should also optimize radiation exposures, especially when CT is chosen over intravenous urography. The partial body CT scan doses are strongly dependent on image acquisition parameters. Once again, think tube current, think pinch, and body location. The organs of highest cancer risk in pediatric cohort is liver in males and ovary in females. I will now talk a bit about the registry data. The registry data are now very different to clinical studies because these are retrospective studies that look at the national registries, and immediately what we can see that now the number of patients are in the tens of thousands rather than hundreds or thousands. The first registry study from HEMA, they identify a total of 68 incidents of cancers, and this was for diagnostic X-ray imaging in a German childhood cancer registries in nearly 80,000 patient cohorts. The results suggest that childhood exposure to diagnostic X-rays is not linked to considerable increase in the incidence of solid tumors or leukemias. The second study of Bakin et al., which is looking again at X-rays of over 90,000 children under the age of 15, had only minor standardized incidence ratios of increases of leukemias, lymphomas, or tumors of central nervous systems. Pascal study that was published recently in 2020 identified that odds ratio was systematically above 1 for cumulative doses about 100 milligrams. So again, we have a threshold for cancer incidence of about 100 milligrams overall. We have studies also published in 2012-2013. The study of 2012 that had 283,000 patients in the registry, with the absorbed doses varied between 5 and 100 milligrams. They correlated the risk of leukemia positively with estimated doses delivered by CT scan to the red bone marrow, and they confirmed their increased risk of brain tumors, which is potentially contradicting to the data from the German registry. So even the registries are not giving us consistent result. The study of Matthews identified, this is an Australian study with 680,000 patients with the mean doses of 4.5 millisieverts, identified 61,000 cancers, including 3,100 that were exposed to at least one CT scan 1 year prior to CT diagnosis. So they concluded that overall cancer incidence was 24% greater in the exposed than unexposed population. They also identified that the absolute excess incidence rate for all cancers was about 9.38 per 100,000 person years at risk. Again, this is though not very large, above that background that 1 in 5 or 1 in 3 person will eventually die from cancer because cancer is a disease of aging population. I will skip this. So this really brings me to the end of my population. What I would conclude that whether we have a clinical data or whether we have registry data, the evidence is still inconclusive. And there are conflicting results in literature. It does appear that imaging with repeated imaging with cumulative doses between 50 and 100 millisieverts being a threshold increases the risk of cancer. The organ where the cancer will appear depends on the body habitus. So if you are imaging head, your primary risk of cancer will be thyroid or maybe breast in females. If you are imaging pelvis, the primary risk of cancer will be liver in males and ovaries in females. Because literature is still contradicting and because we have to apply by Lara principles, we recommend that you always should implement dose reduction technique by using non-ionizing imaging modalities wherever possible, or just use plain radiographs over CT scans. Use dedicated scan protocols for each imaging modality device. Your department should have dedicated pediatric protocols for each body part. If you use an adult protocol for a child, the dose to head, which would be 1.5 millisieverts in an adult, will be 6 millisieverts in a pediatric patient. Implement recording of specific exposure parameters for each patient during procedure, particularly fluoroscopy, for more accurate dose calculations. We need to create national registries for pediatric patients. We need to implement cumulative dose monitoring for long-term risk analysis. And we need to perform comparative dose risk analysis among various imaging modalities for different conditions in order to evaluate the most optimal choice for each case. It's definitely not one size fits all. So I will finish with these take-home messages. I thank you for your attention, and I'm happy to take some questions. My apologies if I went over time.
Thank you, Eva. That was absolutely astounding. There's so much information and data there. I'm sure everyone's heads are reeling in trying to just put it all together.
My apologies if I presented too much. I was just trying to show that it really depends on the anatomy and conditions.
No, it was very cohesively and systematically delivered. But I would like to give the participants the opportunity to put their questions to you. And there are 3 dominant questions from the participants, just so that we can use the time fully. So please, just about a third of the last 8 minutes we have left for each question.
Yeah.
And each of them are very practical questions, which is really nice to see. So the first question, can you make any comment on the repeat daily CBCTs that we're giving to radiotherapy patients? We have the CBCT and it's there to be used and people are using them. And particularly giving large doses in single fractions.
Absolutely, absolutely. Look, this is my personal opinion. I absolutely hate them. I can understand that you should do CBCT for stereotactic body radiotherapy, where you are giving the large doses per fraction in a small number of fractions. So the good positioning is absolute must. But I don't see why you should be giving CBCT, for example, for head and neck cancers, where the patient is immobilized, and secondly, you have a lot of good bony anatomy to be able to identify the good positioning of the patients on a daily basis with bony anatomy. You do have to monitor for the accelerated repopulation, but 1 weekly CBCT is more than enough. And secondly, we can use old methods of measuring the separation, neck separation. What we have to remember that the CBCT produced with KV imaging cannot be subtracted from tumor irradiation dose, because it's a different type of exposure with kilovoltage X-rays, and you are primarily giving dose to skin and superficially positioned organs. You are giving dose to even potentially to the eyes, where the dose to retina is cumulative and does not repair. That's why 1/3 of the airline pilots suffer from optical cataracts later in life. So I think COMBEAM CT should not be used daily, especially, for example, even for prostate. If you are not looking at the 3D volumetric changes and you are only using the seeds to position the patient, there is literature that shows you that the AP and lateral imaging will give you exactly same positioning shift parameters as the CBCT. If you're using COMBEAM CT, then you should be also looking at the changes in the target volume or PTV.
Well, that's certainly suggesting a change in practice for some people.
Look, this is open for the debate. I'm worried that it's sometimes presented to the patient that we are better practice because we do CBCT daily.
I totally agree with you, Eva, but I shouldn't make a comment as the moderator. So do you think that it is timely for that in the prescription of an imaging, be it for CBCT or be it a pediatric imaging, there should be a clear line for justification in terms of what additional information will be provided by this imaging that cannot be acquired in any other way, and how will it change your decision making in treatment. So therefore, a justification in what are you getting out of this?
I would love that. I would love that. There is, I know, some hospitals overseas already also have a decision-making software where in triaging you put patient symptoms. This is also for adults. And the software will actually try to also suggest alternative imaging pathways for a given patient. I know, for example, in UK, if a child is presented with abdominal pain, for example, which is an indication for inflammation of appendicitis, in the olden days, the child would be admitted for observation overnight. These days, the children immediately will get a CT scan, because giving a CT scan is cheaper than one night in a hospital. So we maybe even sort of start thinking what outweighs the risks long term rather than maybe a short term cost saving. I know also groups that would like us to have, and this is where the electronic health record comes into play, that all of those decision-making processes and cumulative doses should be recorded, so that when patients maybe move from hospital to hospital between private and public clinics, the repeated exposures are avoided, and the doctors will get all that information while the procedure was, imaging procedure was delivered.
A question which is a bit curly, but I'll ask it. How can we be sure cancer incidence is purely from the CT or X-ray?
No, you can't. You can't, yes. So the only thing is to study against controls. And even against controls within the registries, you will have to make them you have to base them on gender, you have to make them age control, and you should ideally also lifestyle control them. Because if a person smokes, if a person drinks, if a person has unhealthy diet and weight and doesn't exercise, they are increasing their risk of cancer development. This is very valid question. So that's why the registries where we have hundreds of thousands of patients are very important. And we need to know more about the lifestyle of that patient rather than just whether they had imaging procedures and developed a cancer or not. I think the anecdotal evidence, I heard something. If you are a miner in a uranium mine and you inhale some of the radioactivity, you have a certain risk of developing lung cancer. If you are a smoker, again, you have a certain risk, excess risk to develop a lung cancer. If you are a smoking uranium miner, you have a 1 in 3 risk developing lung cancer, because your lifestyle with the risky environment synergistically increases your risk of lung cancer. So yes, that's very valid question, yes. And that's why maybe we have these different reports coming out from registries.
I was going to ask that. Do you think that there are other factors that are contributing to the contradictions in the data? And I think you've answered that.
Yeah, but also it's, you know, we need international registries. I don't have time to talk to it, and I don't want to take people over limit. The work that came, for example, from Catherine West studies in the UK, one of the fantastic clinical radiation biologists, shows that we have a even in a healthy population, not genetically predisposed for radiation sensitivity, we have a very large variation in the response to radiation. And 80% our radiation response is given by our genetics. We now know it's not a single gene, it's not a signature gene, but it's multiple groups of signature genes that determine how patients respond to radiation. I usually tell this to my students. Ideally, in the future, we should have a quick assays where you can take a sample of blood and an eyelash sample as a early responding and late responding tissue, get a quick profile of that particular patient. And if they are super radiosensitive, then we will not do radiation imaging. So ideally, we would like to see personalized imaging if that can happen. I think Catherine was planning something like that to happen in 2020. I think maybe another 20 years.
Yes, so there the risk is an individualized risk depending on that individual.
Absolutely.
So we are now running 2 minutes over, and all the questions are beginning to come in now. So what I might suggest is that we take note of the questions, and maybe we can
I am happy to prepare a response to any questions that would be recorded in the chat, and Jean can email them to participants, or we can even post them on the AFOMP website.
So Jean, please, if you could keep a record of those questions so we don't lose them when we finish. So this brings me to close this session. I'd like to say, Eva, this has been a privilege to attend this talk. It has really informed me of this very important area. We think always about the immediate treatment that we're giving, but really we need to think about what is the long-term cost, because any procedure someone pays, whether you have a private health system or a public health system, and we usually think of the dollar value of paying. But this is paying in a different way. This is paying in terms of the outcome, the negative effects, the risk for that procedure. And everybody pays when they have a procedure in some way if they live long enough. So thank you very much, Eva, for an excellent presentation. I'm sure all 115 participants and the group sitting at their computers have learned a lot from this session. And thank you, AFOMP, for including such a very important talk in your series of presentations. Thank you. I'll now hand over back to Jean.
May I have one last comment, please? I really would like, we always talk what medical physicists could do. I do feel like that it is very important, if we are living in times of evidence-based health practice, that we know how to do systematic literature reviews and analysis, because this is even, you know, how do you prove that COVID vaccination works? Again, we need to collate evidence from all around the world. So I would say that's another skill that medical physicists can be useful in the department.
I totally agree. Thank you. So thank you. And I close the session.
Thank you, everyone.
Thank you very much, Professor Eva and Professor Natalka, for such a wonderful session and for such a wonderful moderation. And at last, I want to thank all the participants for being with us and making this program a success. Now, I want to invite you all for our next AFOMP school, which will be on 15th of April, which will be on quantization of breast density for predicting breast cancer risk by Professor Kwan Ng. So I request you all to join us for that program. And thank you very much for your time and enjoying the program with us. Thank you very much. See you soon.
Thank you, everyone. Thank you.
Thank you.